Welcome back to Ethics in Physical Activity and Health. Today's topic will be to do a little bit of a deeper dive into some groups of individuals that we often call vulnerable populations. And there's a chapter in your textbook that obviously dives even a little deeper than what we'll talk about today. So I encourage you, of course, to read that. But we actually have mentioned these kinds of groups earlier, and I'll recall you back to that here in a second. But just to start, of course, we're talking about humans and all individuals. And then, of course, in our case, because we're talking about physical activity and health, and so we are gearing it towards our future careers are going to include clients or patients. Those individuals have both legal and ethical rights. So remember that law often reflects society's beliefs about right and wrong, but it's not all inclusive, and not everyone agrees with certain laws that are on the books. But that, like I said, that's up for those ethical dilemmas are certainly, pretty numerous in healthcare, because there's lots of instances that aren't so clear cut when it comes to the law. So anyways, what do? These rights, what are we trying to do? Well, of course, we're trying to protect these individuals from harm. And if you are showing respect to your individual, remember, we treat those individuals as autonomous agents. So the ability to make their own choices. So that's for everybody, absolutely. But there are groups of individuals, certain populations, that are often considered more vulnerable to harm. And so we'll talk about why that is here in a little bit. And so many populations we look at and say that there are additional protections that we should take because they are more vulnerable to harm. And you've seen these already in way back in a very early lecture. I mean, it's not that far, day-wise, but content-wise, it was further back. When we talked about the federal policy for the protection of subjects in research, human subjects in research, our federal law that protects individuals who enroll in research projects. If you'll remember, in 1991, we added subparts, what has come to be known as the Common Rule, and each of those subparts called out groups of individuals. These are all groups that we consider vulnerable populations because we feel that they require additional protections. So I'm just recalling you back that you've heard about this before. So subparts 1 through 4, A through D in the Common Rule include fetuses and pregnant women, prisoners, and minors. So if you'll remember that. And so there are laws related to these populations, and that's one good example of that, so that it can help you guide your decision making and be aware of it. And in addition, there are unique ethical situations that may arise from these populations. I'll just give you one example right now, but we'll talk about it later, are cultural differences. So there may be an individual who comes from a society that believes something very different than you, and that can certainly pose an ethical dilemma when you are trying to provide healthcare services to an individual. This is absolutely not an exhaustive list of vulnerable populations. Of course, if you're looking at the Common Rule, we could also include prisoners on this list. We could include fetuses on this list. But the ones that we will talk about today are minors, elderly individuals, so kind of individuals at each end of life, or if you will, like at each boundary of life. Individuals with HIV and AIDS. And these individuals are called out, but I actually think it includes a few more groups of individuals, and we'll explain why these people are included in this vulnerable population group here in a second. But I also think you could include other diseases within that classification. But I'll get to that here in a second, so just bear with me. And then those cultural differences, like the example I just used. So we'll talk about each of them. In the United States, minors are anyone younger than the age of 18. So if you are 17 and 364 days old, you are still considered a minor. In general, this is absolutely in general, because there are some exceptions, all procedures, so anything regarding health care for minors, requires parental or guardian consent. But there are some exceptions. We mentioned these already, again, a few lectures ago, and it's by state also. So then there are, so generally 18 years is minor across the United States, but in certain states, there are exceptions. So like in California, I believe I shared with you that an individual who is over the age of 12 can seek care for reproductive health without their parents' consent. And I believe that anybody, no matter how old they are, can seek mental health services without parental consent. And so there are exceptions to that rule. And the argument behind that is we want individuals to seek care. And if they feel like they cannot or do not want to tell their parents about it, then we wouldn't want to deprive them of those services like mental health services. So that's the argument for having such a young age on some of those services, or no age requirement at all. So think about this. We'll just jump right into an potential ethical dilemma. What happens if the minor does not agree with the decision of a parent? Or what if a minor wishes to seek medical advice without a parent? There is some good news. There's some good news, that's why I put question marks. There are some laws and ethical principles which can help you decide on the right course of action. However, if you go back to that 3-step decision-making model, the first one is it legal? So you certainly don't want to lose your license. You don't want to ruin your reputation by not following the law, because you can get in trouble in addition to that. So you have to go back to, is it legal, as that first kind of step, right? But then you have to kind of be aware of the laws, and then, of course, know where to consult or who to ask about if you need help with that. So just thinking back here. So what happens if the minor does not agree with the decision of a parent? Sometimes it comes down to the age of the minor. And so let's just move on here real quick, because here's always the question mark. It's that autonomy question mark. So can this person make decisions concerning their own personal business? So the legal age of autonomy is 18. However, you can have autonomy established with the legal system. So what I mean by that is in this dilemma, let's say a minor, here's an example actually, and this is a real example. What if you have a 16 or 17-year-old who has cancer and wants to be treated for it, but their parents, because of their religious beliefs, do not want the child to be treated? And there are some religious beliefs that don't believe that. So in that instance, you absolutely have an ethical dilemma. You have obviously 2 points of view. It's a moral issue regarding treatment and the saving of a life. So let's just go with that scenario, right? There's a million we could come up with. But let's say a minor wants to be treated. They're 16 years old, and their parents do not want them to be treated for a disease that could potentially be deadly. That person, it would probably go to the ethics committee at a hospital in that example, and then the legal system could step in. So when that happens, an individual, like a minor, depending on their age and their level of autonomy, may be granted their own rights to treatment, like I said, in that instance. So if they're 16, and when you get into 16 and 17 years old, it becomes a little bit more difficult because these people probably can make pretty good decisions for themselves. When I was 16 or 17, I probably could have made some decisions that I would still make today. There are probably a lot of decisions I wouldn't make either, but that's besides the point. But anyways, so these 16 and 17-year-olds that are still technically minors may be able to make perfectly good decisions, but they are under the age of 18. So that's when you kind of get into, like I said, some ethical dilemmas. They don't happen all the time. A lot of times parents and children agree, and, course of treatment happens without any problem. So the families and the parents, obviously, like any of our decisions that we make or any of the beliefs that we hold, we're going to look at our values. We're likely going to look at our resources. So resources sometimes being money, sometimes being, equipment or facilities or whatever else we have or need, and then our needs. So as a healthcare professional, what do you do? Well, like I said, you do have to follow the law, but that doesn't mean that if you feel like something is wrong, that you can't seek help. So the first step, though, is definitely, and this is just dependent on what career you go into, but as a healthcare professional, you should be providing information and education to help parents make decisions for their minors. You should give them, if possible, various choices, alternatives, and then if you know, consequences for those alternatives. So, okay, here's the alternative, but here's what could happen if we go with this line or whatever. And really, then once that's provided, because you do want to provide information and allow them to make decisions, then respect for that decision. So your role in general as a healthcare professional is to advise, right? However, like I said, sometimes, and I hope this is rare, it has certainly been rare in my instance, in my profession. I have not seen problems arise because of this. But sometimes healthcare professionals will feel that family decisions conflict with the best interest of the child. And that's why I was going back to that example earlier is kind of one that has happened because, let's say, a parent decides not to treat their child, and that may conflict with how you feel as a healthcare professional. Especially in our instance, or in our example, we have this child who has cancer, and let's say you're the healthcare professional and the prognosis is good. So with treatment, you would expect this child to have a relatively normal and long life. So that's where some of these things have arisen. So when that happens, you can consult, and like I said, it just depends on the career that you're in and the organization you're working for. If it is some kind of hospital or medical system, then they will have a legal counsel or an ethics committee that can help you. So you can consult where there are conflicts. Especially if we're talking about between parental decisions and what the medical community would consider the best interest of the child. And there have been instances in which the legal system says the child will be treated. There was a pretty famous case, actually I think your textbook talks about it, so read that, but there was a pretty famous case some years ago where the parents, again, this is a religious example, where parents did not want to treat the child, and the child was very young. So now let's forget that it's a 16 or 17-year-old, but let's say they're 2 years old. And clearly a 2-year-old is not going to be able to make an informed decision about cancer treatment. Let's say it's cancer. And so there was a ruling, a really famous ruling, that ruled in favor of the medical community, said the child had to be treated, let's say for cancer, because there was no guarantee that that child was going to grow up and follow the religious practices of their parents. So they might, but they might not. And so they were projecting and saying, hey, when this person is 18 or 20 or 50, there's no guarantee that they're going to have the same religious beliefs as their parents. And because of that, we're going to treat them so that they have the potential to grow up to be that age. Because without treatment, this child will not last or it will live very long. So that's an example of that. So the example I used earlier was one in which we have an older minor. And these get a little bit more difficult because, like I said, a lot of teenagers can probably make some sound decisions. Most states, because most of this is states, for these individual type cases or rules, it's at the state level. So most states consider anyone less than 12 years old incapable of truly understanding and in making informed decisions about themselves or their health care. But once they're over 12 years old, you get into this situation where you may. So once a teenager, if you do have a legal issue regarding treatment, then a court's going to consider lots of factors, of course, state laws, regulations, what's the problem, what's the procedure, what's the maturity level of the teenager, what's their parental situation, so on and so forth. And so they're going to consider those factors when they're trying to figure out what's the best interest of this minor. A waiver of parental consent. So parents do not have to give consent in treatment in emergencies, especially if they're not there. Obviously, it's implied. We'll talk about that here in a second. And when there is any potential or suspected parental sexual abuse, and if a child has mental health or substance abuse services, they can, like I said, in California, I gave you the California law, where they do not have to have parental consent to seek those services. Some states have a mature minor doctrine, so that's why I kind of chose the age of 16 earlier, where some states provide greater autonomy to minors that are 16 years and who understand and consent. Typically, these are relatively minor things, but certainly can be all the way up to life-threatening conditions. And as I've already mentioned several times, especially with those examples, if parents and minors do not agree on the course of action, then the legal system may intervene, weigh all of those factors here that you saw, and make a decision. Okay, so that's minors. Now let me make one more. I'll reiterate one more thing I just said, because in an emergency, again, if you're at a practice, let's say you're an athletic trainer, if you're at a practice and parents aren't there and there is an emergency and you're working with a bunch of kids under 18 years old. Emergencies, you don't have to have parental consent to treat. Again, it's implied. It's implied that in an emergency situation, most parents would say, yes, help my child. So I just want to reiterate that a little bit more clear before we move on to the next group of vulnerable populations. So this is minors, or some considerations about minors, but in general, we're talking people under the age of 18 years old. Elderly clients and patients. Now, elderly clients and patients, this is a little bit more difficult because there's no real set age here. In many government programs and systems, there are set ages, to collect Social Security or Medicare. If you're 65, you're eligible for Medicare, so on and so forth. So in those instances, Yes, we have some age requirements, but their elderly population, although generally thought of as over 60 years old in our society, there are people who are much, much older who are completely autonomous. And there are people who are younger than that who start to have some health issues and maybe not are not completely autonomous. So as we age, and as we near kind of the last chapter of our life, I know that sounds morbid. There are ethical dilemmas that can arise due to end of life and end of life care. And that's where we'll kind of talk about today with this group of individuals. In order to potentially help mitigate those problems. So hopefully you won't have any ethical dilemmas that arise, but you might. If you have some legal documents in place, it may help your family and healthcare providers do what you wish. So, this is a list of things that, and this doesn't have to be elderly, by the way. Just luckily in our society, we have a pretty high life expectancy, and so this is more common for elderly patients, but all of these things can happen at any time of your life. So you can be 25 years old and have these things in place. Absolutely. But like I said, just as you get older, it becomes kind of more in the forefront of your thinking, perhaps. So anyways, as you are thinking, I hate to make you do this, but, as we're thinking about end of life, you have things called advance directives. And advance directives outline the health wishes in the event that you're unable to communicate or you're no longer considered competent for whatever reason. And this can be due to physical or mental disabilities, dementia, whatever it might be. You can write down or you can do an advance directive that outlines your health wishes. You may also do a DNR order, do not resuscitate order, which means, and this is a legal document, this means that you do not want extreme measures taken to save your life. This would include CPR and AED. So this means if you go into cardiac arrest, that a healthcare professional or any professional should not be attempting to save your life. And DNRs, people can elect these, but also DNRs are often, I don't want to say recommended, that's probably not the best course of, or the right wordage for this, but, if you have a terminally ill patient, they may decide that that's better. Just do the DNR. A living will indicates if you want to be put on life-supporting machines or life-prolonging machines. So this would be life support, breathing apparatus, feeding tubes, those kinds of things. And that can be different than a DNR. Obviously, it is different than a DNR because a DNR means that you don't want them to bring you back. A living will would be, do you want to be put on life support? And some people will, and it may change, obviously, as you go through your life. All of these documents, I should mention that, all of these documents can be edited and altered and redone. And then power of attorney legally allows someone to make decisions on another's behalf. And this can be financial, this can be healthcare. So the biggest ethical and legal issue when it comes to the elderly population is that of competence. And obviously competence, if you'll remember back, refers to the individual's ability to make decisions necessary for living independently. Yes, a person can be declared incompetent at any age for a variety of reasons. Like I said, could be physical or mental disability, certain disease, whatever, degenerative type things. However, we see this more in elderly populations when it's related to age-related dementia and Alzheimer's, loss of critical thinking skills. So elderly individuals, you really need to consider, you need to be very, I don't want to say careful. Careful is not the right word. Be very, remember seeing red. Respect, empathy, and dignity. I personally believe that it's even more important to practice that with the elderly. So your role as a healthcare professional is to act within your scope of practice, not to make the decisions for them. You have to respect the decisions that they wish, which can sometimes be hard. But once you give the information and the education that you wish, you have to respect their wishes. Elderly patients are often, here's another really important dilemma for this population, because also as a society, we're getting older. So we are aging and we're living longer, which is great. But that means also that we need medical care for longer. That's just a reality. And elderly individuals often also seek more medical care than younger individuals, because we do start to have physical, and other problems. So a lot of times elderly individuals are faced with high medical bills. And we do have some social programs that hope or attempt to help out with some of those costs. So you've heard of these, I'm sure. Medicare. So Medicare is a federally sponsored program. So this is at the federal level, the national level, for adults that reach the age of 65. But you can get Medicare if you are younger and you have a disability. Certain disabilities qualify you for Medicare. Medicaid is not just an elderly patient program. It provides healthcare assistance to low-income individuals and families. And there's stipulations, there's certain requirements that you have to meet for these programs, especially Medicaid. Here's why I bring it up. Besides, of course, you being aware of what they are. Providers are not required to accept Medicare and Medicaid, and some do not. So this is a controversy, then this can be considered an ethical dilemma if an individual wants to seek medical care and that provider does not accept Medicare or Medicaid, because they're not required to. A lot do. And in some cases, it may not be that big of a deal. So if there's, let's say, actually, I don't think my dentist accepts these programs. Anyways, let's say you recommend a doctor to somebody, they have Medicare, they call to make an appointment, they say, oh, I'm sorry, we don't accept Medicare. But you live in a big city and you go, okay, no problem, that's a bummer, but I'll go to another doctor that accepts Medicare. Sometimes that's not that easy, depending on the area that you live in. Think about more rural areas and how elderly patients may not be able to drive or may not be able to travel long distances due to their health conditions. And so that is a controversy that you may hear about. And I just thought I'd throw it out there for you because chances are you will also eventually work in a healthcare facility that may or may not accept Medicare and Medicaid. Next set of vulnerable populations, explicitly in your textbook outlines HIV and AIDS patients. But I'd like to again add that this isn't just HIV and AIDS patients that could be considered a vulnerable populations, but other communicable diseases that have stigmas associated with them. What do I mean by that? Well, HIV and AIDS and other communicable diseases, I'm thinking hepatitis as a good example. The most common ways that those are spread are by unprotected sexual contact or IV drug use. Both of those practices are not often considered very upstanding behaviors in our society. And so that's what I mean by that they have stigmas associated with them. I hope it's getting better. I don't know if it is. But remember back to the ADA, that law that we previously talked about, that came about in 1992 when the HIV and AIDS epidemic was relatively young. And so it is specifically mentioned in ADA and HIPAA. So regarding these individuals, specifically for HIV and AIDS, I'm talking now, once a person is diagnosed, they are actually supposed to inform others. Legally, once a person is diagnosed with HIV, they are supposed to notify all past, present, and future sexual partners and their current healthcare providers. But there's no real check on that. So that is truly something that is left to the HIV positive individual, although the law requires them to do that. However, HIV positive individuals, they aren't required to share their status with coworkers, employers, their school. Like I mentioned before, sexual partners, needle sharers, and their healthcare team are the only ones that are legally required to share your status with. You're not required to share with your workplace or your school. And of course, why? That's because we want to try to protect these individuals from discrimination because of the stigma associated with that communicable disease. But if you are an HIV positive healthcare provider, you do have to tell your patients. So, they're supposed to tell you, you don't have to share with your workplace, but in the healthcare industry, you are supposed to tell your patients. So it's a little bit of an interesting situation there. And a good reason why also, besides the fact that this group is a vulnerable population because of the stigma associated with the disease, there's also some legal considerations around this population. And then the last one that I'll mention today are cultural differences, and there's no way to go through all the different groups that have different potential different values, beliefs, diets, cultural practices, but please be aware of them. So other groups may be considered vulnerable because they're not really integrated into our U.S. healthcare system. And that can be for a variety of reasons. Like I said, there's no way to be able to recap them or to be able to get them all, especially in this one video lecture. But think about things like ethnic differences and cultural differences, economic, geographic differences, or other health characteristics. And so just be very aware that when you're working with people, they may have varying needs from other groups. So listen. Listening is good. Learn as much as you can about that individual. Ask questions in a respectful way. And try as much as you can, to meet specific requests if at all possible. So this may not be a cultural thing, but it could be. I see this a lot among lots of groups, actually. If you have a male healthcare provider having a female present in the room with you. Like I said, that doesn't have to be a cultural difference. I see that a lot, but it could be. That's a pretty easy request to meet. There are some cultures who believe white is actually associated with death. And so if you are a physician or a nurse and you're wearing a white lab coat, and that becomes apparent to you, just take off your lab coat when you go and see that patient. But if there are other things that cannot be accommodated, think bedside manner, think red, respect, empathy, and dignity, acknowledge, perhaps try to compromise, or just explain why that request cannot be made or cannot be completed. And so that's very situational. And so think about kind of where you're going to do as your career. Maybe think about potential scenarios that may pop up. And if things can be accommodated or not. So again, your textbook author loves acronyms, and this is still a good one. This is another good one, the HELP model. So here, and this goes for, I think this is good for every patient or client, but something to doubly consider when you're talking about vulnerable populations. HELP, H, hear what the patient perceives to be the problem. Listen. E is encourage the patient and professional to discuss similarities and differences. L is list treatment options and make recommendations. And then P is provide a chance to negotiate treatment. And that's, explicitly, if you're having some of these cultural differences, then you can kind of fall back to this or think about it, and it might help navigate that situation a little bit better. We have mentioned this before, but I do want to re-mention it because we're talking about vulnerable populations. Mandatory reporting laws. So there are laws, of course, requiring lots of professionals, but pretty much every kind of healthcare professional has to report suspected cases of abuse. And some of you won't be maybe right in healthcare, you may be in education or social work. Guess what? They're probably mandatory reporters too. And so you are mandated to report any suspected child abuse, elder abuse, domestic abuse. And you're protected, right? Meaning that you have to have some justification for it, but you don't have to necessarily be completely right. So like, for instance, if you have a child, and there's a questionable injury, maybe you see a sign of neglect, maybe they're losing weight. Whatever you think is the case here. You cannot be sued if you're incorrect. So let's say they investigate, child legitimately, broke their arm playing baseball, no big deal. But you can be held responsible for not reporting it if you suspect that it's child abuse. For elder abuse, we're talking about things like intent. These are just examples because you have to kind of fall back also on kind of, what you're seeing. Intentional harm, neglect, exploitation, abandonment. Unfortunately, you see this in the elder community. Like I said, in our society, generally, elder is considered above 60 years old. And then domestic abuse. This goes for any domestic abuse, actually, not just marital. This can be between roommates. This can be between domestic partners, not just spouses. But this is willful intimidation, assault, or other abusive behavior by a family member or intimate partner. So, kind of wide range there of relationships that can be potentially, reported if you believe they fall under the domestic abuse, if you suspect domestic abuse. So there you go. Again, a few more thoughts about these groups of individuals that we often consider vulnerable populations. I hope that you, at this point in the semester, if you will, the session, we're 3/4 of the way there. I hope you're starting to appreciate kind of some of these things that you see every day and you've maybe never stopped to think about. I hope you are potentially doing that a little bit more. And overall, I hope you're enjoying kind of the different topic within healthcare. So as always, ask questions, let me know how you're doing, and take care.